Okay, hi everyone. My name is Hannah. I am a rising junior at Hamilton College, and for this webinar, we will be talking about autism and epilepsy with a focus on epilepsy as a disorder and the relationship between the two. First, I want to thank everyone for participating in my webinar. I want to give a huge thanks to Med Q&A for sponsoring this, and I want to start with a disclaimer. I am not a doctor or a medical professional. This webinar is for educational purposes only and to give you insight based on my experiences. I'm working with the American Autism Association this summer, and for this webinar, I'll be presenting for approximately 20 minutes. After I finish, I will open up the floor for questions, and in that time, please ask questions because I would love to answer, and questions only help this community grow. For the duration of the presentation, mics will be muted to eliminate outside noise. At the end of the presentation, I will unmute the mics and you can ask your questions. If you are not watching this webinar live, please feel free to go to medqa.com and record your question. I or someone in the autism community will be able to respond. Okay, now let's begin the presentation. So this is my webinar, Autism and Epilepsy, Understanding What to Do and the Connection. Today I will be covering what epilepsy is, the types of seizures, how to recognize epilepsy, the process of diagnosing epilepsy, treatment, the connection between autism and epilepsy, and finally, the resources for families with autism and epilepsy. First, I want to start with, what is epilepsy? Epilepsy is a neurological spectrum disorder characterized by recurrent seizures. An epilepsy means a person has had more than one seizure that was not triggered by a temporary condition such as a fever. A seizure is a result of abnormal electrical firing in the brain that disrupts normal brain functions. Seizures can take on many forms and vary in types and outward appearance. Someone having a seizure may stare blankly for several seconds, which may be barely noticeable, or his body may shake uncontrollably for a period of minutes. Since I'm talking about the relationship between autism and epilepsy, I will also tell you what autism spectrum disorder is. Autism spectrum disorder, or ASD, is a neurobehavioral disorder that includes impairment in social interaction and language development, which often involves rigid, systematic, repetitive behaviors. Both conditions can affect individuals with varying degrees of severity. And that's what a spectrum disorder is. Severity varies from individual to individual. Next, I'll talk about the types of seizures. There are 6 main types: the tonic-clonic, the absence, the tonic, the clonic, the myoclonic, and the atonic. The tonic-clonic or grand mal seizure is the most common. It involves muscle stiffening followed by jerking and also produces loss of consciousness. It can be dangerous if continued for 15 or more minutes. Next, the absence or petit mal seizure involves period of unresponsiveness, staring into space, and may or may not exhibit jerking or twitching. The tonic seizure is muscle stiffening alone. The clonic seizure involves repeated jerking movements on both sides of the body. The myoclonic seizure involves jerking or twitching of the upper body, arms, and legs. And finally, the atonic seizure involves sudden limpness or loss of muscle tone and an involuntarily dropped head. Seizures aren't always obvious, but they can still contribute to sleep and behavior problems. They may first begin in either adolescence or adulthood. According to the Epilepsy Foundation, there is no one type of seizure associated with ASD. All types of seizures are possible. However, there is higher mortality and morbidity associated with seizures in ASD. Some people with ASD are more prone to seizures than others. Individuals with ASD and certain genetic disorders together are more likely to have seizures. These disorders that are associated with both seizures and autism include Rett's, Fragile X, Engelmann, Prader-Willi, and many other syndromes. Next, we'll move on to recognizing epilepsy. After you've seen specific symptoms that are characteristic of epilepsy, such as unexplained staring spells, stiffening of muscles, involuntary jerking of limbs, involuntary face twitching, unexplained confusion, or severe headaches, you should suspect epilepsy. There are also less specific symptoms that may be confused with other disorders. These involve sleepiness or trouble sleeping, unexplained irritability or aggressiveness, and regression in normal development. These symptoms of epilepsy may be difficult to recognize because of communication barriers and overlap of symptoms with frequent abnormal behaviors in autism. Some types of seizures may be harder than others to notice because their symptoms, such as staring and failing to respond, sometimes with repetitive motions, look like symptoms of autism itself. After you have seen one or all of these symptoms, then you should look to a diagnosis. First, you should seek evaluation by a neurologist. They will most likely give you an electroencephalogram or an EEG. An EEG is a non-invasive process that involves the placing of electrodes on the head in order to monitor activity in the brain. Symptoms and developmental complications of ASD can sometimes mask the effects and signs of a seizure. Thus, to really diagnose epilepsy, an EEG is necessary to determine if there are abnormal electrical discharges that may be interfering with brain function or could indicate increased risk of epilepsy. Any ASD clinical evaluation should also include screening and assessment of seizure risk, since seizures are the most common neurological problem in ASD. However, an EEG involves placing electrodes on the head and sitting still for a long period of time, which may be difficult for an individual with autism. That's why there are other neurodiagnostic tests possible. These neurodiagnostic tests include neuroimaging, laboratory evaluations, genetics, and a neuropsychological evaluation. Neuroimaging using an MRI or magnetic resonance imaging is the most common to assess for significant structural abnormalities or malformations of the brain. Other neuroimaging technologies are positron emission tomography or PET scans, single photon emission computerized tomography or SPECT scans, MR spectroscopy or MRS scans, and diffusion tensor imaging or DTI scans. Laboratory evaluations are next. There are a wide variety of relevant laboratory tests of the blood, urine, cerebrospinal fluid, and skin or muscle tissue. These can help identify a biological cause of epilepsy and/or ASD. Next, you could use advanced genetic testing technologies so scientists can understand, diagnose, and treat epilepsy and ASD. In many cases, the sequencing of thousands of genes of interest can be obtained with just a saliva sample. Genetic testing can also provide information concerning risk, susceptibility, and prevention of complications of epilepsy and ASD, sometimes with implications for other family members as well. And finally, a neuropsychological evaluation is possible. Neuropsychological evaluations include a series of tests that measure quantitatively and qualitatively brain function, processing, and output. Next, we move on to treatment. There are several options, with the most popular being an anti-epileptic drug, but others include ketogenic diet, vagus nerve stimulation, surgery, and safety measures by caregivers. Due to the spectrum aspect of epilepsy, each treatment should be individualized and personalized and include programs that encourage healthy lifestyles such as exercise, a good amount of sleep, nutrition, and stress reduction. Therapies should be included in which they identify and target the biological mechanisms that trigger epilepsy while also trying to reduce and ease the process of seizures. First, anti-epileptic drugs, depending on type and severity of seizures and their associated EEG patterns, can prevent or minimize seizures. Other than that, there are adjunctive non-pharmacologic therapy if medications fail, and these include the ketogenic diet and vagus nerve stimulation. The ketogenic diet is high protein and fat and minimal carbs. This diet mimics starvation by burning fat for energy rather than carbs. And vagus nerve stimulation is a type of neurostimulation technique that prevents seizures by sending pulses of electrical energy to the brain through a device. For surgery, it involves the surgical removal of seizure-producing areas of the brain. And the easiest, and anyone can do this, safety measures by caregivers involves during the seizure. When an individual is having a seizure, avoid restraining the individual, move large objects from the area to avoid injury, turn the individual on his or her side, and ensure nothing is in the mouth to avoid choking. Unrecognized and untreated, epilepsy carries a risk of injury from seizures, which includes trauma, drowning, aspiration, and rarely, sudden unexpected death in epilepsy, or SUDEP. SUDEP is more likely in people with uncontrolled grand mal tonic-clonic seizures, or those who are having seizures but not taking adequate doses of anti-epileptic medications. Causes include pauses in breathing, heart rhythm problems, brain dysfunction, or a mixture of these. In addition, behavior, development, memory, or learning could be negatively affected. In those individuals with autism spectrum disorder, having an associated diagnosis of epilepsy can actually increase the risk of mortality sevenfold. And now we'll be moving on to the connection between autism and epilepsy. First, I want to start by saying not all children with autism have seizures. Similarly, not all children with epilepsy will have autism. There's just a strong association between the two. Since 1943, when Leo Kanner was the first to describe the clinical and personality traits of individuals with autism and its connection with seizures, we have found a strong connection between autism and epilepsy. 70 years ago, psychiatrist Leo Kanner published a case study of 11 children with a condition he called autistic disturbance, which now we know as autism spectrum disorder. One child, a young boy with autism known only as John F., also had convulsions. This was the first reported link of autism and epilepsy. According to the organization Autism Speaks, autism and epilepsy tend to co-occur in 15 to 30% of individuals. There are certain risk factors for epilepsy and autism. These include age, genetic conditions, and intellectual disability. For age, seizures seem to begin most often in two spikes, the preschool years and the teenage years. For genetic conditions such as tuberculosis sclerosis complex, Fragile X, or 15q duplication syndrome, as mentioned before, when these genetic disorders are in addition to autism, epilepsy is a higher risk. According to the Center for Neurological and Neurodevelopmental Health, individuals with neurodevelopmental disabilities and brain disorder are more likely to develop epilepsy. In children with ASD, intellectual disability is a major risk factor for developing epilepsy, with an estimated risk of 8% for those without intellectual disability and as high as 20% in those with intellectual disability. Generally, any brain disorder will increase the predisposition for seizures because of the lower threshold needed to surpass in order for a seizure to occur. Thus, people with ASD are more prone to seizures than others. Individuals with autism are at high risk of developing epilepsy and vice versa. According to Autism Speaks, about 5% of those who develop epilepsy in early childhood also develop autism. According to Arkansas Children's Hospital Research Institute, some individuals with ASD develop seizures in childhood, puberty, or adulthood. The risk of seizures remains high into adulthood, as recent studies suggest. So there is no one age that is associated, or you would think that a seizure may occur. It's possible at all ages. And this is specifically so because ASD and epilepsy appear to have similar biological and anatomical mechanisms in the body. Research with biotechnology has revealed that there are many types of genetic variations and mutations that cause and/or contribute to both ASD and seizures. Seizures are the most common neurological complication in autism, as mentioned before. And in the diagnosing slide, as I said, it can be difficult to pinpoint a symptom as epilepsy because of overlap of symptoms, including cognitive delay, impaired social interactions, aggressive and irritable behavior, and thus it is difficult to discern the cause. Is it epilepsy or is it autism? There are some underlying mechanisms for autism and epilepsy, including abnormal synaptic plasticity, imbalances in excitatory and inhibitory neurotransmitters, and disruptions in the developing brain. Next, we'll move on to the resources for families with autism and epilepsy. First, there's explaining seizures, there's information on the EEG procedure, there are guidebooks, and there are bed monitors. In explaining seizures to those with epilepsy and peers, I've provided links to guidebooks. There are visual stories in which you can explain to children and their peers what is a seizure, what is epilepsy, and what to do in those situations. For information on the EEG procedure, including how a child's ASD diagnosis might impact the experience and how to help children with ASD successfully prepare for and complete an EEG, I have also provided a guide to EEGs. Since EEGs are fairly difficult for individuals with autism because it involves gluing electrodes to an individual's head and sitting still for quite a long time, this guide should be quite helpful. EEGs can be difficult for all individuals, but they can be especially so for individuals with autism. Here are some tips for parents of children with autism getting an EEG or caretakers for individuals with autism. Caretakers or parents can talk with their child's doctors and providers about what each person involved in the EEG can expect. This will help lower parent and child anxiety about obtaining EEGs and also help the EEG process go faster. Oftentimes, being right next to the individual with autism while being hooked up or getting the electrodes glued to the head could be reassuring and also helpful in keeping hands away from the electrodes being glued to the scalp. Reinforcement after each step of the procedure is done is always a good way to keep things going and to avoid negative reactions that will interrupt the procedure. Approach the EEG procedure as a team effort between family and hospital staff, and this will require communication and flexibility among both parties. In addition, having a guide or a toolkit will definitely help parents feel more confident about helping their child complete an important medical procedure by informing them of the sensory aspects of the complex procedure. This would help prepare their child or the individual that they're taking care of for what they will experience. That's why I've provided a guidebook to help parents with seizures on individuals with ASD. And finally, there are bed monitors to monitor individuals during sleep. They detect movements and can differentiate sleep movements from seizure movements. These will be especially helpful for individuals with autism because they may not be able to communicate that they need help. And that is the end of my presentation. I will now unmute all the mics and open the floor for questions. Thank you all.
Hannah, I have a question.
Okay, yes.
Regarding the severe headache, when it comes to the absence form of the seizure.
Yes.
If a child is pretty young, how do you know, how can they explain to you that they're having that severe headache?
Oh, okay, that's a good question. I think if a child is nonverbal, an individual with autism is nonverbal, then it is most likely you would have to rely on other symptoms, or they would tell you, they would try to communicate in other ways how they're having the severe headache. Oh, sorry, I lost you.
No, I'm here.
Oh, okay.
Yes.
I think the way they would communicate, even if it's not verbally, they would explain, they would point to their head. I think body language is a large indicator of how individuals are feeling. And if severe headaches or other symptoms that have to be communicated are not possible for you to understand, then other symptoms could be recognizable.
And that would also imply regarding the staring spells also?
Yes.
I know some kids do that. They just kind of stare into
Right.
nowhere for long periods of time. So,
right.
I mean, that's something that you definitely would think they're having a seizure or not necessarily.
Yes, I agree. I think those staring spells especially are really hard to diagnose as, oh, that's epilepsy. So I wouldn't say that should be the one symptom you should look out for. I would say the other symptoms are probably more recognizable, but I do think staring spells are common and characteristic of epilepsy.
Okay, thank you.
Thank you very much.
Hannah?
Yes.
I got a question.
Okay.
the ketogenic diet,
Yes.
low carb, high fat diet,
Yes.
would it be a stretch to say that someone with autism may want to lower or restrict their carb intake then in general, or no? Would it be kind of a stretch to?
Um, are you asking, should individuals with autism want to lower their carb
Yeah,
intake?
like if even if they don't have any kind of epileptic um um
Oh,
um um, um uh, you know, what's the
right.
word, conditions,
Hmm.
episodes, right?
Yes.
But would it sort of, if they wanted to be sure that they didn't have that kind of a situation happening, would I mean,
Okay,
without.
I think I understand. I think the ketogenic diet isn't harmful in any way. So if an individual with autism does want to try it out in case, just in
Yeah.
case there's a possibility of having epilepsy, I think that's fine to go through with. But I
Or
would.
maybe not necessarily the whole diet, but just to keep, as a general rule, to watch their carb intake. Then you know what I'm saying?
Oh, okay.
Yeah,
I think I wouldn't know because I'm not a
yeah,
nutritionist or a
yeah.
doctor. But if you wanted to, I don't see the harm in doing so.
Okay, okay, all right. Thanks.
Thank you for your question.
Hannah,
Yes.
if a child is diagnosed with ASD,
Yes.
they don't necessarily have to have seizures. Well, they don't necessarily have seizures, but at some point the seizures can appear,
You're right.
correct?
Correct.
As they develop,
Yes.
yeah? Okay,
Yes.
so what I guess you should look out for indications or, yeah? Yes?
Okay. So indications, as I said, seizures can erupt at any age. So you should always be on the lookout
Mm.
for any individual with autism. They're the most common
Mm.
neurological complications. So I would probably say if you are worried about it, look out for the symptoms that I mentioned. Staring spells would be difficult for individuals with autism. So in symptoms that overlap, like staring spells, a lack of paying attention, and things like that, I wouldn't try to focus on those symptoms, but instead focus on symptoms such as the stiffening of muscles and the involuntary jerking of limbs and unexplained confusion or severe headaches. If you see those, then I would recommend you going to a neurologist.
But are they likely to occur, because you said like in the preschool age, are the seizures more likely to occur during the preschool age or when they get older?
That's hard to say because I looked up this psychologist and she said that they come in two spikes, preschool and adolescence. So it's hard to really pinpoint, oh, at preschool age they're at the highest risk.
Mm-hmm.
It's variable. It depends on the
Okay.
individual. So
Okay. All right. Thank you.
So I know you said that people with autism, that seizures is the most prominent neurological dysfunction when it comes to
yes.
that. So what are maybe the secondary and tertiary ones, if you know?
Oh, okay. That is a good question. Well, since autism is a developmental disorder, there are a lot of neurological complications other than seizures, but I would not say that I know.
Okay.
I'm sorry.
That's fine.
But thank you for your question.
I have a question. How realistic is it to try to teach an autistic child how to prepare for a seizure?
I think you're right. It's not very realistic because even for individuals without autism, there is no proper way to prepare for a seizure. So in trying to teach an individual with autism how to prepare doesn't make the most sense, but just having them informed of what's happening to them, because when you come to from a seizure, it's very confusing and you may not remember what happened. So just informing them of what might happen to them and what to expect, I think, is preparation.
And you think they'll be able to understand that?
I think having the preparation is important regardless of or not whether or not they understand, because if there is the possibility of them understanding, even if they can't communicate to you that they do understand, I do think they should know. Does that make sense?
Thank you. Is there a cure for epilepsy?
I have not found in my research that there is a cure. I've only found treatments.
Okay, thanks.
Thank you for your question. Okay, if that is all, then thank you everyone for participating in this webinar. I'm sorry if I wasn't able to answer your questions, but thank you for your questions, and I hope you all have a great night.
Thank you. Good night.
Thank you.
Good night.